Hyperglyceridemia is an metabolic disease. Look at this picture, shows that signs and symptoms and disease mechanisms. Detail going on. Introduction. Hypertriglyceridemia refers to elevated levels of triglycerides in the blood. Triglycerides are a type of fat lipid that the body uses for energy. While they are essential in moderate amounts, excessive levels can lead to serious health complications, including cardiovascular diseases and pancreatitis. A definition: hypertriglyceridemia is a condition characterized by elevated levels of triglycerides in the bloodstream, typically above 150 mg per dl. It is often associated with metabolic disorders, insulin resistance, and an increased risk of cardiovascular disease and pancreatitis. Classification: hypertriglyceridemia is defined as fasting serum triglyceride level above 150 mg per dl. It is classified based on severity. 1. Borderline high 150 to 199 mg per dl. 2. High 200 to 499 mg per dl. 3. Very high more than 500 mg per dl. Etymology: the term hypertriglyceridemia comes from Greek and Latin roots. Hyper, Greek, meaning excessive. Triglyceride from the Latin tri meaning three, and Greek glykios meaning sweet, referring to glycerol backbone with three fatty acids. Anemia, a Greek haima meaning blood. It describes a condition characterized by an excessive level of triglycerides in the bloodstream. Types: 1. Primary hyperglyceridemia. Genetic disorders affecting lipid metabolism such as familial hypertriglyceridemia and familial combined hyperlipidemia. Second, secondary hypertriglyceridemia caused by lifestyle factors, underlying diseases, or medications. Causes: 1. Lifestyle factors: high fat diet, excessive alcohol intake, sedentary lifestyle. 2. Medical conditions: diabetes mellitus, hypothyroidism, kidney disease, liver disease, metabolic syndrome. 3. Medications: beta blockers, steroids, estrogen therapy, diuretics. 4. Genetic factors: inherited lipid metabolism disorders. Risk factors: 1. Obesity. 2. Poor dietary habits. 3. Sedentary lifestyle. 4. Smoking and excessive alcohol intake. 5. Family history of lipid disorders. 6. Diabetes and metabolic syndrome. 7. Chronic kidney or liver disease. Complications: 1. Cardiovascular diseases, increased risk of atherosclerosis, heart attack, and stroke. 2. Pancreatitis, severe hypertriglyceridemia, more than 500 mg per dl can trigger acute pancreatitis. 3. Non-alcoholic fatty liver disease. 4. Insulin resistance and type 2 diabetes. Pathophysiology: triglycerides are transported in the blood by lipoproteins, primarily chylomicrons, and very low density lipoproteins in hypertriglyceridemia. Increased triglycerides synthesis due to excessive calorie intake or insulin resistance. Impaired lipoprotein lipase function leading to decreased triglyceride clearance. Accumulation of triglycerides in the plasma due to genetic or metabolic abnormalities. Pathophysiology of hypertriglyceridemia: step by step process. 1. Excessive triglyceride production or intake. High dietary intake of fats and carbohydrates leads to increased triglyceride synthesis in the liver. Excessive calorie consumption promotes the conversion of carbohydrates into triglycerides via de novo lipogenesis. 2. Impaired lipoprotein metabolism. Triglycerides are transported in the blood via very low density lipoproteins and chylomicrons. Lipoprotein lipase LPL, an enzyme in the capillary endothelium, breaks down these lipoproteins into release free fatty acids for energy use. LPL deficiency or reduced activity due to genetic factors, insulin resistance, or certain medications leads to inefficient triglyceride breakdown. 3. Accumulation of triglyceride rich lipoproteins. When LPL activity is insufficient, BLDL and chylomicrons accumulates in the blood. This results in elevated serum triglyceride level, an hallmark of hypertriglyceridemia. 4. Hepatic overproduction of BLDL. In condition like insulin resistance, the liver increases VLDL synthesis to store excess fatty acids. This further raises triglyceride levels in the circulation. 5. Reduced triglyceride clearance. Defects in apolipoproteins, example APOC2 deficiency needed for LPL activation, impaired lipoprotein breakdown, hepatic clearance of triglyceride rich remnants like chylomicron remnants is reduced. 6. Association with insulin resistance and metabolic syndrome. Insulin resistance decreases LPL activity and increased hepatic VLDL production. High triglycerides contribute to small, dense LDL particles which are more atherogenic. 7. Potential complications. Pancreatitis, excess chylomicrons and BLDL can lead to pancreatic inflammation. Cardiovascular disease, CVD, high triglycerides promote block formation in arteries. Non-alcoholic fatty liver disease, NAFLD, excess triglycerides accumulate in the liver, causing fatty liver disease. Hypertriglyceridemia is often a result of genetic predisposition, metabolic disorders like diabetes, or lifestyle factors such as a high fat diet, obesity, and alcohol consumption. Signs and symptoms. A. Often asymptomatic. B. Severe cases, mainly more than 500 mg DL. 1. Pancreatitis, abdominal pain, nausea, vomiting. 2. Eruptive exonthomas. 3. Hepatosplenomegaly, enlarged liver and spleen 4. Lipema retinalis, milky appearance of retinal vessels. Diagnosis: 1. Lipid profile measures triglycerides, total cholesterol, LDL and HDL. 2. Fasting blood sugar and HbA1c to check for diabetes. 3. Liver function test LFTS to assess liver health. 4. Kidney function test to rule out renal involvement. 5. Thyroid function test to check for hypothyroidism. 6. Genetic testing for familial lipid disorders. A nursing diagnosis: 1. Imbalanced nutrition, more than body requirements related to excessive dietary intake. 2. Risk for impaired cardiovascular function related to elevated triglyceride levels. 3. Deficient knowledge regarding lifestyle modifications. 4. Acute pain related to pancreatitis in severe cases. 5. Risk for non-compliance with medical management. Disease management: A. Lifestyle modifications, diet control, exercise, weight management. B. Medications: 1. Fibritis, example fenofibrate, gemfibrozil, first line for severe cases. 3. Omega-3 fatty acids, fish oil, lower triglycerides. 3. Statins, example atorvastatin, rosuvastatin, primarily for cholesterol control but also reduce triglycerides. 4. Niacin, vitamin B3, lowers triglycerides and improves HDL levels. Nursing management: 1. Educate patients about healthy dietary choices, low fat, high fiber diet. 2. Encourage physical activity at lowest 150 minutes of moderate exercise per week. 3. Monitor lipid levels and medication adherence. 4. Assess for signs of pancreatitis or cardiovascular complications. 5. Support patients' emotional well-being and provide counseling. Treatment options: 1. Dietary changes, low fat, low sugar, high fiber diet. 2. Physical activity, at least 30 minutes of exercise most days. 3. Weight management, achieving and monitoring a healthy BMI. 4. Medication therapy for patients with persistent high levels. 5. Regular monitoring, periodic lipid profile test. Psychosocial medicine. 1. Health education, teaching patients about the risk and lifestyle changes needed. 2. Motivational counseling, encouraging adherence to treatment plans. 3. Behavioral therapy, helping patients overcome unhealthy eating habits. 4. Support groups, connecting patients with similar conditions for peer support. 5. Stress management, teaching relaxation techniques to manage stress which can impact lipid levels. Prevention. 1. Maintain a healthy diet low in saturated fats and refined sugars. 2. Engage in regular exercise. 3. Avoid excessive alcohol intake and smoking. 4. Maintain a healthy weight. 5. Manage underlying conditions like diabetes, hypothyroidism. 6. Regularly monitor lipid levels if at risk. In conclusion, hyperglycemia is a significant risk factor for cardiovascular diseases and pancreatitis. Early detection, lifestyle modifications, and medical interventions can effectively manage and prevent complications. Thank you. Have a nice day.